Good afternoon, everyone. Welcome to the update on COVID management protocol 2021, the second wave. Myself, Dr. Nagesh, practicing anesthesia intensive care. So, introduction to this COVID-19. This coronavirus are important human and animal pathogens. At the end of year 2019, a novel coronavirus was identified as a cause of cluster of pneumonia cases in Wuhan. It's a city in Hubei province of China. It rapidly spread, resulting in epidemic throughout China, followed by an increase in number of cases in other countries throughout the world. In February 2020, World Health Organization designated the disease as COVID-19, which stands for Coronavirus Disease 2019. That virus causes COVID-19 is designated Severe Acute Respiratory Syndrome, SARS-2 COVID. Previously, it was referred to as 2019 novel coronavirus. So current strains in India are current COVID-19 cases may be a mixture of various strains. Apart from the previously known strain, a new double mutant strain of SARS-CoV-2 virus has been detected in India. This is in addition to the UK, South African variant and Brazilian variant of the virus already circulating in 18 states of the country. How variant strains differ from first wave. New virus strain have two mutations, is highly infectious and has a potential to skip the immunity developed either by natural infection or vaccines. That's why it is not uncommon to see reinfection cases and cases among vaccinated people. Newer strains are not only more transmissible, affect the younger population and can lead to more severe illness. Salient observations. Age pattern, a shift in the age group of critical patient towards a younger age group. Younger patients are not only getting affected but requiring ICU admissions. Bypassing RT-PCR, new COVID cases may not be detected in some cases by routine RT-PCR tests. There are more thrombotic complications as compared to cases in 2020. No one is superhero after 2 doses of vaccination. Patients are getting admitted with the symptoms to hospital after 2 doses of vaccines also. But this is in most of the cases asymptomatic, mild or moderate with a high CT value on RT-PCR, suggesting low viral load and have a low potential for transmission. However, they are a little safe. Middle to high socioeconomic group appears to be affected more. However, this can affect any socioeconomic strata. That's an observational opinion. Is mortality more? Severe disease and death may occur even in the absence of comorbidities. Deterioration may be very fast. This strain this time appears to be more virulent. Few centers observational opinion it is. ICU admissions and deaths are sensitive indicators of regarding lethality of the COVID-19 2021. CT lesions are veiling radiologists. The worrisome thing is that 1% a percentage of cases showing CT lesions are far more than the CT lesions appear more diffuse, suggestive of ARDS pattern this time than during the first peak. This is an observational, personally communicated data from the few centers in Maharashtra and Gujarat. What is new? In 2020, speculations were being made that SARS-CoV-19 has a seasonal occurrence spreading more in the cold, cozy days in Italy. However, 2021 virus proved everyone wrong, showing no favorite weather predictions. Surface transmission of virus is unlikely to be a threat now as per as new CDC information. Possible air transmissions remains more of the theory, with most of the physicians reverting to use of nebulizers, BiPAP machines, and other aerosol generating processors with due precautions. Is RT-PCR not relevant always in such cases? Ideally, RT-PCR should detect COVID-19 cases by all strains, but still, some newer variants may be missed. According to WHO, some mutations like HV69/70 have the capability to affect the RT-PCR testing as well and may go undetected in the tests. But the impact of new mutation in the RT-PCR test being deployed worldwide is expected to be minimal. It is advisable to read the full RT-PCR report, which may still show ORF gene and N gene, but the S gene may not be detectable. Some laboratories may interpret this case of S gene dropout as negative. How to diagnose such cases? Well, it's based on the clinical features, serum markers, CT scan of the chest should be used for diagnosis where clinical suspicion is high if RT-PCR is negative. Time is the game changer. The entire management of COVID, it is always important to identify the first day of illness. It is for all the management issues. The day of RT-PCR must be taken as for all the decisions. This is most transmissible on day prior and 3 to 4 days after the first symptom. For initial 2 to 3 days, patient is likely to have high fever because of high replication of the virus. But at this time, innate immunity by macrophages, neutrophils, etc. starts mounting defense against the attack towards the virus. The beginning of second week herald the worsening of symptoms, which is immune-mediated inflammatory response characterized by high-grade fever, increase in oxygen demand and hypoxia, etc. Unchecked hyperinflammation lead to COVID cytokine storm syndrome and multi-organ damage. So it is utmost important to act swiftly on the 7 to 10 days by use of anti-inflammatory medications. Most of currently used medications like corticosteroids, tocilizumab, convalescent plasma work best when given in time during this phase. Incubation period, symptoms may develop 2 days to 2 weeks following exposure to the virus. Current estimation of the incubation period are in the region of 4 to 5 days. So timely action. Corona is not a lung disease, it's a systemic thrombo hyperinflammatory vasculitis disease. Virus is non-replicating after 9 days. Fever of more than 101 degree Fahrenheit, CRP more than 10 milligram per liter, a rapid rise of CRP, cough on day 3 or a fall of saturation SpO2 on 6 minutes walk test by 5% are suggestive of pneumonia. Day 5 is the day in the critical phase, according to the Pfizer et al. Lancet 2020. Day 90 is the day when the word COVID ends positive RT-PCR. Beyond this period, should not be considered as reinfection or persistent virus shredders as updated by CDC. Loss of smell is the symptom equivalent to RT-PCR test. 15 minutes the time to get the infection. The moment you get the patient, review comorbidities is very, very important. because many times we will be focusing on COVID-19, but patient will be having multiple comorbidities, like majority of them having diabetes, coming in DKA, hypertension, ischemic heart disease, patients will be immunosuppressants, cancer and chemotherapy patients, patients post-transplant patients. All these things should be kept in mind. Every patient, we have to assess their comorbid condition. Comorbidities makes the patient more vulnerable, and we tend to neglect on the comorbidities, focus the COVID-19 management, and they succumb because of the comorbidities. That should not happen. So adequate management of a comorbid conditions is very essential in case of treating COVID-19 disease. So review the comorbidities, history of the contact, travel, old and the recent medical record, including recent chest radiograph, any available core adds 4 out of 5, the likelihood of COVID-19 is high. These kind of things has to be checked on arrival. Assessment of vitals, saturation, SpO2, heart rate, NIBP, respiratory rate, all these things has to be done. Send ABG if saturation, that is SpO2 less than 94% on room air, or patient in the respiratory distress. Better immediate results will be there. You can find out the hypoxia. Inform consultant on duty. Take a chest X-ray PVU, or chest X-ray for not much use here actually. Better to do a CT thorax and advised by the consultants. Review the history, vitals, chest radiology, and inform consultants on duty. Shift the patient to isolation facility in the holding area till the patient gets admission in the required bed. SARS-CoV-2 PCR testing for all the suspect cases and family members. So frequently reported signs and symptoms of the patients that includes fever, usually low grade, that is 77 to 98% of population with COVID positive have fever. Cough in 46 to 82%, dry throat and dry cough will be there. Myalgia, fatigue will see in 11 to 52% of population. Loss of smell, which is a no sense corona. Loss of taste, jaggery taste, that is a throat corona. Shortness of breath, 33 to 31% lung corona. Happy hypoxia, patient will be comfortable talking, walking, but when we check their saturation, it should be very low. Even I have seen patients talking and very comfortable with the saturations of 60%, which are impending to collapse. Low hand grip strength, 6 minutes walk test, plan 3 to 6 to 6 to 5% desaturation can happen. Any symptoms of close contacts, any symptoms like loss of taste, smell, left eye redness, any of the symptoms like a fever, throat irritation, signs of breathlessness, loss of loose motions, headache, nausea, vomiting, rash, pain, ballooning, cystitis, anorexia, altered sensory, all these things can be symptoms of COVID. Classification of COVID patients clinically, so mild, moderate, and severe. The clinical criteria based on the saturation, respiratory rate, symptoms, chest X-ray, and average of percentage involvement of each lobe, that is a CT chest criteria. So saturation more than 94% on room air considered as a mild, 90 to 94% on room air considered as a moderate, saturation of less than 90 on room air considered as severe. So respiratory rate of less than 24 considered as mild, respiratory rate of 24 to 30 is moderate, more than 30 considered as severe. And symptoms, in mild cases of fever may be there, may not be there. Moderate cases, fever with breathing difficulty. Severe cases, fever with respiratory distress. Chest X-ray evaluated 3 zones in each lung, upper, middle, and lower zones. In chest X-ray, it will be normal in case of a mild. Moderate cases, it will be there with pneumonia involving 1 zone. In severe cases, pneumonia involving more than 2 zones. CT chest criteria, the average of percentage involvement of each lobe. So in mild cases, less than 25%, moderate less than 50%. In severe cases, it's more than 50% involvement. Risk factor for the disease severity, that again, age more than 60 years. However, we are seeing many patients, young patients less than 30 to 45 people falling ill and becoming sick and going on ventilator support. However, prognostic factors risk is high in case of elderly population, more than 60 years, especially one who are having comorbidities. Presence of any significant comorbidities, as I said, like coronary artery disease, patient with history of myocardial infarction, PCI, or CABG within previous 6 months. Cerebrovascular accident within last 6 months, patient heart failure with NIH class 3 and class 4, chronic respiratory disease, that is COPD, bronchial asthma, interstitial lung disease, and etc. Poorly controlled bronchial asthma, daily use of salbutamol inhalers for symptoms or nocturnal symptoms. Patient with hospital visits for exacerbation within last 1 month. Uncontrolled diabetes with the HbA1c of more than 9%, random glucose of more than 300 mg per deciliter, systemic hypertension with a systolic BP of more than 140 and diastolic BP of more than 90, or diastolic BP more than 90, patient with active cancer and chronic kidney disease patients. These are all adds to the risk factors. Critical care interventions, patients in respiratory distress with difficulty in airway, respiratory rate of more than 30, unable to speak full sentence, patients in cyanosis or saturation of SpO2 less than 85% and room air, ABG-PF ratio of less than 250, systolic blood pressure of less than 90 despite of fluid resuscitation, patients who are agitated, confused, comatose with respiratory distress, early modes, that is 2 or more organ failure, curve 65, that is confusion, urea more than 40, respiratory rate more than 24, BP of systolic BP less than 90, age more than 65, score of 3 or more, called curve 65, may severe as useful prognostic marker in COVID-19 patients, which could be used to quickly triage severe patients in primary care or general practice settings. SOFA score 2 or more had, that is hypertension, altered mentation, and tachypnea. All these patients should have critical care interventions. Investigation in admitted patients, preference made with CBC, look for red cell distribution width and neutrophil lymphocyte ratio, which is important. Markers like CRP, LDH, LFT, KFT, RVS, HbA1c, and urine protein with the microscopy. HbA1c as a clear predictor of COVID-19 severity shown in a few studies. ABG, blood culture, minimum 2 set of blood culture with elevated serum procalcitonin levels. Sputum gram stain after RT-PCR if patient is having a sputum. Nasopharyngeal swab for qualitative RT-PCR. Chest X-ray PUV, screening CT thorax if there is a diagnostic dilemma. Our CT thorax to see the severity scoring is important. ECG, D-dimers and ferritin. CKMB, NT-proBNP tropine, PT-INR before initiating the anticoagulant. Echo Doppler of the heart, as we get an echo done in all elderly patients, suggested for specific cases. Usually all elderly patients are patients with comorbidities. We are doing CT thorax. These are the day 1 tests, that is hematologically, lymphocyte count, neutrophil lymphocyte ratio, NLR, inflammatory markers like CRP, ESR, erythrocyte sedimentation ratio, procalcitonin, immunological markers, that is interleukin IL-6, IL-10, IL-6 to IL-10 ratio, biochemical markers, D-dimers, troponin, creatine kinase, AST, that aspartate aminotransferase, ferritin, LDH. Suggested marker of infection are most commonly ferritin, LDH, and CRP. This will be elevated. The table showing lab findings in case of mild, moderate, and severe disease. neutrophil NLR ratio, neutrophil to lymphocyte ratio. In case of mild, it's less than 3.5%. Moderate, more than 3.5%. Severe case, severe it is more than 5.2%. Neutrophil to lymphocyte ratio. CRP in mild cases less than 20, moderate 20 to 50, severe cases 50. We have seen CRP going up to 200, 300. Ferritin of mild cases less than 500, moderate more than 500, and severe cases are more than 800. D-dimer less than 500, moderate in case of 500 to 1000, severe cases of more than 1000. D-dimer has gone up to, I've seen a case of 18,000 D-dimer, so high. LDH less than 30 mild cases, moderate cases it's 300, less than 300 mild, moderate is 300 to 400, severe cases it's more than 400. IL-6 levels in case of mild it is less than 5, moderate 5 to 50, and severe that is rising more than 50. IL-6 levels goes more than 200, 300, even as we have seen up to IL-6 go around 800. LFT mild may be normal, moderate cases slight derangement, severe cases there may be moderate derangement. Red flag signs if developed likely to deteriorate, that is neutrophil lymphocyte count of more than 3.5. Raised CRP, ferritin, D-dimers, LDH, PF ratio of less than 300, eosinophenia, that is zero eosinophil syndrome. So these are all red flag signs. One should be vigilant in case of when fever is more than 101 Fahrenheit with drugs, or more than 103 Fahrenheit without antibiotics. Persistent cough starting after 3 days, sudden onset of shortness of breath, or a rapid rise in CRP. More than 50% lung involvement on CT, that is a score of from 13 to 13 out of 25, and auditory sensorium. So monitoring of cases, that is comorbidities and complications. Comorbid complications should be treated appropriately. Seek expert opinion whenever it's needed. So monitoring of BP and heart rate should be done daily in case of mild, moderate cases 6 hourly. Continuous monitoring required in case of severe patients. Monitoring of respiratory rate, assess of dyspnea and saturation 6 hourly in mild, 4th hour in moderate. Continuous monitoring is required in case of severe patients. CBC, NLR, RFT, LFT should be repeated every second day in case of mild and moderate, and daily it has to be repeated in case of critical patients or severe patients. D-dimer repeated every 4th day in mild, every second day in moderate, once in every 2 days to be indicated in case of severe patients. Troponin CKMB repeated in 24 hours and 36, once in 2 days in case of moderate, once in 2 days in case of severe also. Baseline ECG should be taken in case of mild and moderate, whereas continuous ECG monitoring is required in case of severe patients. APG is required only in case of severe patients. APG required patients admitted critical care on a daily basis. Chest X-ray is indicated in case of patient who are deteriorating, or indicated in patient of who are in the critical care. Chest X-ray not mainly to see the progress of the disease, to see the complications like the pneumothorax. It's very important. These patients, chronic, severe patients who are on either ventilator support or NIV, who are in ICU for long period of time, tend to have any fibrosed lung causing pneumothorax or rupture of the existing in COPD patients because of the high pressure ventilations. So chest X-ray should be repeated every day to rule out any complications, or whenever you see fall in saturation or bradycardia, those conditions also suspect the pneumothorax, which is very common in COVID lung. So chest X-rays should be repeated daily and whenever indicated. In case of mild cases, symptomatic patients meeting the case definition of COVID-19 without evidence of viral pneumonia or hypoxia, respiratory rate of 24, monitor saturation, NIBP, heart rate, temperature, rehydrate them, use antibiotics, nutritional support, No role of azithromycin or doxycycline. Most of the centers expert use these drugs on personal experience and have found them useful. However, we are not using any azithromycin doxycycline. Oral vitamin C, vitamin D, zinc supplements. There is on HCQ. There is no solid evidence. No evidence for ivermectin as well. It has a weak antiviral property in high concentration, difficult to achieve that with therapeutic current dose in the pulmonary endothelium. Still, few state guidelines recommend them. Favipiravir is a weak antiviral drug with a limited value, may clear the virus, but most may not be needed, especially those with mild cases. Prophylactic dose of low molecular heparin if a risk factor for thrombotic disease, that is enoxaparin dose of 1 mg per kg OD and 40 mg OD for all, or fondaparinux 2.5 mg subcutaneous in high risk patient where thrombocytopenia or ITP, TTP patients. In moderate illness, consider D-dimer re-estimation on day 4 or earlier if respiratory deterioration is there. Rise in D-dimer, consider CTPA, 2D echo, lower limb Doppler, use low molecular heparin. Where imaging not feasible, provided there is no contraindication. Oxygen supplementation by nasal prongs if saturation is maintained between 90 to 94 on room air, or patient who on our heparin. Injection oxalate clavulanic acid 1.2 gram IV TDS plus or minus azithromycin 500 OD if bacterial infection is suspected. Injection dexamethasone 6 mg IV OD if oxygen supplementation is needed, or methylprednisolone 40 mg to 120 mg per day. Injection remdesivir, which is 200 mg IV on day 1, followed by 100 mg OD, that is between day 2 to day 5. Consider remdesivir in patients who are RT-PCR positive for SARS-CoV-19 more than 18 years. 18 years, more than 18 years old, pneumonia confirmed by chest imaging, oxygen saturation of 95% or lower on room air, or a ratio of arterial oxygen percent pressure of fractional inspired oxygen, that's PF ratio of 300 or less, and were within 10 days of symptom onset. Remdesivir role is in the first 10 days, reduces symptom duration, but no mortality benefits. CT severity score more than 8 out of 25 can use in patients with the CT severity score less than 8 with dense consolidation rather than clone glass opacities. High fever without riser CRP, especially in elderly patients and with comorbidities and even with normal CT2. Use in hospitalization is important for all age groups to ensure the remdesivir. Remdesivir is available through an FDA UA for the treatment of COVID-19 in hospitalized patients with emergency approval. In pediatric patients weighing 3.5 kg less than 40 kg or aged less than 20 years of weight, weighing of more than 3.4 kg. Caution while using remdesivir. No data exists about safety in pregnancy or during breastfeeding. Avoid if hepatic cirrhosis, AST or ALT more than 5 times the upper limit of normal. Known case of severe renal impairment, estimated glomerular filtration rate of less than 30. Then or a recipient of continuous renal replacement therapy, hemodialysis or peritoneal dialysis. However, many centers are using remdesivir if clearly indicated. In compensated cirrhosis patients, really compromised patients, and patients on hemodialysis with careful monitoring without any major issues. So remdesivir is a vastly used drug now. Remdesivir use it early as the saturation starts declining. Early than the oxygen requiring stage, especially if 6 minutes walk test is positive, with steroids and heparin along with it as per your decision in individualized to your patients. Wait for 3 to 4 days for the clinical improvement. However, used after the patient desaturates with a higher oxygen requirement, it may not be helpful. So remdesivir used in early stages is helpful compared to use after 1 week or later or patients in critical stage. Case of moderate illness, positioning of the patient is utmost important. 30 minutes to 2 hours lying on your belly. 30 minutes to 2 hours lying on your right side, 30 minutes to 2 hours sitting up, 30 minutes to 2 hours lying on your left side, and then back to the prone position. Photo below shows to demonstrate how one has to lie down. So try to be in the prone position maximum time, at least of 12 to 16 hours one should be in the prone position. Then every second hourly there's positioning change and lateral position to supine position on the either sides. Anticoagulant treatment. Time for anticoagulant treatment. So as per anticoagulant guidelines, all moderate and severe symptomatic COVID-19 patients aged more than 8 years with a clinical presentation pulse rate of more than 110, respiratory rate of more than 24, saturation less than 94, either hospitalized or in-home treatment, should receive anticoagulant prophylaxis until contraindicated with the bleeding disorder or low platelet counts. Even with a low-grade fever with a dry cough or sore throat, COVID-19 patients and pneumonia should be suspected in home-treated cases to avoid future emergencies. If clinically pneumonia is suspected by the history and the clinical presentation of the disease, pneumonia is confirmed by X-ray chest or CT scan chest, then low molecular heparin should be initiated on day 5 or in case of a high-risk group on the day 1. Treat the viral period in a symptomatic phase with antivirals. Treat immune system in inflammatory phase with inflammatory steroid. Use early anticoagulation to avoid thrombophilia in pulmonary phase. Steroid alert. Steroid should be strictly avoided in asymptomatic patients. Mild symptoms of less than 7 days. CT score of less than 8 with a disease duration less than 5 to 7 days. Viremia phase where high fever with the normal CRP and CT score. Steroid should be used in all moderate to severe cases in all patients with a saturation of less than 94, irrespective of the day of onset of symptoms. All these patients should receive 40 to 120 mg of methylprednisolone per day or dexamethasone 6 mg per day. Role of steroid in a mild case COVID-19 disease. Mild cases, second week with a fever, malaise, myalgia, headache, fatigue, can use low dose such as methylprednisolone 4 to 16 mg per day, which is equivalent to steroid 5 to 7 days. Any other steroid. This statement is based on the expert opinion only. Anti-inflammatory steroid should be initiated early in pulmonary phase to counter the immune dysregulation. Ideal time for the steroid initiation is after the 8 days of symptoms when virus has a very low tendency to replicate and the inflammatory response is persistent. Steroid consideration revisited. Anti-inflammatory steroid should be initiated in early in pulmonary phase, counter the immune dysregulation. Ideal time for the steroid initiation is after 8 days of symptoms, as there's tendency to replicate an inflammatory response is persistent. However, it must be emphasized that corticosteroids should not be used in mild cases, mild disease, early on the course of COVID-19 illness if indicated. The overall pooled estimate observation study and RCTs has shown significantly reduced mortality in corticosteroid group. For patients who have significant lung involvement, defined as a resting saturation of less than 94% or 6 minutes walk test showing a drop in oxygen saturation by 5% or more, and patients may be initiated an injection methylprednisolone 0.5 to 1 mg per kg per day, preferably in 2 divided doses, equivalent dose of dexamethasone. Patients on corticosteroids can be followed up if their oxygen requirement inflammatory markers such as CRP are going up. The dose can be escalated to 2 mg per kg per day of injection methylprednisolone for a brief period till the patient stabilize, and then we can taper down the dose of 1 mg per day and then 2.5 mg per day. Some centers use pulse therapy with a higher dose of methylprednisolone with a dose approaching to 500 mg 1 gram methylprednisolone per day Although this approach is not sustained with the multiple or large multi trials and RCTs. Higher dose of steroids are used after a meticulous exclusion of bacterial co-infection and are tapered off at the earliest. Dose of 0.5 to 1 mg per kg methylprednisolone can be used for an extended period of 10 days or more. Steroid treatment, right time, right drug, right duration, very important. Methylprednisolone is better than dexamethasone and dexamethasone is better than prednisolone. Methylprednisolone penetrates much better into the lungs and binds to much better into the glucocorticoid receptors among all the steroids. So it gives the best anti-inflammatory response. Cytokines. Alert for cytokine storm on day 7 and day 8 of disease to be ruled out from the group with moderate illness onwards. Cardinal features of unremitting fever, cytopenia, hyperferritinemia, pulmonary involvement including CORADs. Clue for cytokine storm, yes, we can predict if patient in the second week having signs of breathlessness even with the previous normal CT, rising the CRP above 50, CT worsening, fever onset in the second week, etc. Points towards impending cytokine storm, daily CRP monitoring and steroid dose adjustment are crucial here. Cytokine storm management, methylprednisolone, pulse 250 mg to 1 gram per day for 3 days, injection tocilizumab, monitoring clinical symptoms, saturation, CRP, D-dimer, and serum procalcitonin levels. Case of severe illness, assessed by signs of pneumonia, if any of the following, like saturation less than 90% on room air, respiratory distress, respiratory rate of more than 30 per minute, patient showing rapid progression that is more than 50% on CT imaging within 24 to 48 hours. Oxygen delivery by nasal cannula, face mask, venturi mask, or mask with reservoir bag plus or minus NAB. Consider a broad spectrum empirical antibiotic treatment for possible suspected bacterial pneumonia infection in or if procalcitonin is significantly high, leukocytosis or leukopenia. Injection dexamethasone 6 mg IV OD for 1 to 10 days. Injection enoxaparin 40 mg OD subcutaneous or fondaparinux 2.5 mg subcutaneous OD. Injection remdesivir 200 mg IV OD followed by 100 mg for 5 days or TAF favipiravir 1800 mg BD on day 1 followed by 1000 mg BD. However, favipiravir is not used now. Consider tocilizumab, injection tocilizumab that is 8 mg per kg body weight, maximum up to 800 mg. 400 mg IV over 60 minutes. Use a dedicated IV line by infusion set. Do not infuse other agents through the same line. Repeat CRP D-dimer after 12 hours. If rising trend, persistent fever, then may repeat the dose after multidisciplinary team discussion. Itolizumab, made in India, undergoing trials, can be used in place of tocilizumab if not available, and it's cheaper. Consider tocilizumab in patients aged more than 18 years. Real-time RT-PCR diagnosed with a SARS-CoV infection, presence of lung infiltrate, saturation that is PF ratio of less than between 200 to 300, presence of exaggerated inflammatory response defined by the presence of at least one of the following criteria: at least one body temperature measurement of more than 38 degrees past 2 days, or serum CRP greater than or equivalent to 10 mg per deciliter. CRP increase of at least twice the basal value, D-dimer of more than 2500 nanogram per ml, or serum ferritin more than 500 nanogram per ml, with worsening hypoxia despite 24 to 48 hours of corticosteroids and supportive care. Tocilizumab can be considered only in the right setting in steroid unresponsive increase or severe hypoxia, which the inflammatory pathology is indicated as a cause of hypoxia, not to be used in all patients. Note, patient attendants need to be provided drug information sheet. Proper information consent has to be taken before administering remdesivir and tocilizumab. Discharge policy following state-specific guidelines, if any, that is a discharge from mild, moderate, severe cases. Discharge criteria afebrile more than 3 days without antipyretics and patients who are non-breathless. 10 days from the symptom of onset, in mild, moderate 10 days from the symptom of onset, in severe cases after clinical recovery. Moderate cases, patients who are not on oxygen for last 3 days, RT-PCR need not to be repeated. Thank you. I'll be discussing on COVID-19 disinfection. So, environmental cleaning, disinfection, biomedical waste management. Environmental decontamination, that is the cleaning of medical equipments, cleaning of soiled bedding, towels, and clothes from the patients with COVID-19, cleaning and disinfection of occupied patient rooms, prevent environment contamination, contain respiratory secretions. Cleaning and disinfection after a patient discharge and transfer, biomedical waste management. So, environment decontamination, that is the general principle. Healthcare environment contain a diverse population of microorganisms, but only few are significant pathogens. Microbiologically contaminated surface can serve as a reservoir of potential pathogens. Contaminated surface are not directly associated with the transmission of infection, so to either staff or patients. Transfer of microorganisms from any environmental surface to patient is mostly via hand contact with the surface. Hand hygiene is important to minimize the impact of this transfer. Cleaning and disinfection environmental surface is fundamental in reducing the healthcare associated infections. Environmental decontamination, that is COVID-19 virus can potentially survive in the environment for several hours to days. Premises and areas potentially contaminated with the virus to be cleaned before their reuse. Products containing antimicrobial agents known to be effective against coronavirus may be used. Established clinical strategy to be used, remove the majority of bioburden and disinfect the equipment and environmental surfaces. Environmental decontamination, that is housekeeping surface, can be divided into two groups. Those with minimal hand contact, example floors and ceilings, and high-touch surfaces, those with frequent hand contact. High-touch housekeeping surfaces in a patient's care area should be cleaned or disinfected more frequently. That is, doorknobs, bed rails, light switches, wall area around the toilet, in the patient room, edges of the privacy curtains. Wear gloves when handling and transporting use of patient care. Before removing equipment from the patient room, medical equipment must be disinfected. Non-critical medical equipments, for example, like stethoscope, blood pressure, BP cuff, dialysis machine, and equipment knobs and controls, usually only require cleaning followed by low to intermediate level disinfection depending on the nature and degree of contamination. In absence of manufacturer instructions regarding the cleaning and disinfection of the equipment, ethyl alcohol or isopropyl alcohol often used to disinfect small surfaces, that is, rubber stoppers of multiple multi-dose medical vials and thermometer, and occasionally external surface of the equipment, stethoscope and ventilators. Alcohol causes a discoloration, swelling, hardening, and cracking of the rubber and certain plastics after prolonged and repeated use. Cover mattress for easier disinfection. Barrier protection of difficult to clean surface and equipment is useful, especially if these surfaces are touched frequently by gloved hands during the delivery of patient care, are likely to become contaminated with the body substance or impervious backer paper. Plastic or fluid resistance covers are suitable for use of as barrier protection. Remove and discard coverings with gloved hands. Perform hand hygiene after ungloving. Cover the surfaces with a clean material before the next patient encounter. Areas, inputs, process, methods for the procedure. How to clean stethoscope? Stethoscope should be cleaned with alcohol-based or spirit-based part cleaning. Should be cleaned with a detergent and water, and should be wiped with alcohol-based spirit swab before each patient. BP cuff and covers, detergent, hot water, washing. Cuffs should be wiped with alcohol-based disinfectant, and regular laundering is recommended for the covers. Thermometer. So detergent and water, alcohol scrub, individual thermometer holders. Cleaning process should be stored dry in individual holders. Clean with detergent and tepid water and wipe with alcohol rub in between patient use. Store in an individual holder inverted, preferably one thermometer for each patient. Injection dressing trolley, detergent and water dusters, cleaning to be cleaned daily with the detergent and water. After each use should be wiped with disinfectants. Cleaning soiled bedding, towel, and clothes from patients with COVID-19. Clean the laundry and surface in all environments in which COVID-19 cases receive care at least once a day and when a patient is discharged. Hospital disinfectants, 70% ethyl alcohol for a small area, reusable dedicated equipment, sodium hypochlorite for surface disinfection. Individuals, staff dealing with soil bedding, towels, and clothes from patients with COVID-19 should be wear appropriate PPE with a heavy-duty glove, mask, eye protection, long-sleeved gown, apron, and boots or closed shoes. Never carry soiled linen against the body. Place a soiled linen in the leak-proof bag or bucket. Perform hand hygiene after blood body fluid exposure and after the PP removal. Cleaning of soil bedding and towels, clothes from the patients with COVID-19. Soil linen should be placed in clearly labeled leak-proof bags or containers, carefully removing any soiled excrements and putting in a covered bucket to dispose of in the toilet or latrines. Washing machine, wash at 60 to 90% with the laundry detergent followed by soaking in 0.1% of chlorine for approximately 30 minutes and should be dried. Non-washing, no machine washing, soaked in hot water with a soap detergent in the large drum. Use a still and avoid splashing. Empty the drum and soak linen in 1.1% chlorine for approximately 30 minutes. Rinse with the clean water and let linen dry fully in the sunlight. Cleaning and disinfection of occupied patient room. Designated specific well-trained staff for cleaning environment surface. Cleaning personnel should wear PPE and must be trained and proper use of PPE and hand hygiene. Define the scope of cleaning to be done each day. Use checklists to promote accountability of the cleaning responsibilities. Keep cleaning supplies outside patient room. Cleaning of housekeeping surface and eating utensils. Housekeeping surface require regular cleaning and removal of soil and dust. Personal protective equipments used during cleaning and housekeeping procedures need to be cleaned only with soap and water or detergent and disinfectant, depending on the nature of the surface and degree of contamination. Dish and eating utensils. Dish and eating utensils used by the patients with known or suspected infection. No special precaution other than the hand precaution. Wear gloves when handling patient's tray, dish, and utensils. Spill management. Workers assigned to clean the spill should be wear glove and other personal protective equipments. Most of the organic matter of the spill to be removed with absorbent material. Surface to be cleaned to remove the residual organic matter. Use disinfectant hypochlorite. That is 1% for the small spills and 10% for large spills. Cleaning and disinfection after patient discharge or transfer. Clean and disinfect all surface that were in contact with the patients or may have become contaminated during patient care. Do not spray or fog occupied or unoccupied rooms with a disinfectant, potentially dangerous practice that has no proven benefits. Prevent environment contamination, contain the respiratory secretions. Ensure early recognition and the prevention of transmission of respiratory virus at the initial encounter with the healthcare setting. Post visual alert in appropriate language at entrance of the outpatient facility. Example, emergency department, physician office, outpatient clinics. Instruct patients and other persons who accompany to them. Inform healthcare personnel of the symptoms of respiratory infection when they first register for the care. Practice respiratory hygiene and cough etiquette. Respiratory hygiene, cough etiquette. All persons with signs and symptoms of respiratory infection must follow respiratory hygiene and cough etiquette. Cover the nose, mouth with cough when coughing or sneezing. Use a tissue to contain the respiratory secretion. Dispose of the tissue in the nearest waste receptacle after the usage. Perform hand hygiene after contact with the respiratory secretion and contaminated object materials. Prevent environment contamination. Contain respiratory secretions. Ensure availability of materials for adhering to the respiratory hygiene cough etiquette in waiting areas for the patients and visitors. Provide tissues and no-touch receptacles, that is waste containers with foot-operated lid or uncovered waste containers for user tissue disposal. Provide conveniently located dispensers of alcohol-based hand rub. Provide soap and disposable towel for hand wash where sinks are available. Masking and separation of persons with the symptoms of respiratory infection. During periods of increased respiratory infection in the community, offer a triple layer mask to the person who are coughing. Encourage coughing persons to sit at least 3 feet away from others in common waiting area. Droplet precaution. Healthcare workers should practice droplet precautions in addition to stand precautions when examining a patient with the symptoms of respiratory infection. Droplet precautions should be maintained until it is determined that they are no longer needed. Biomedical waste management. Yellow bin. Yellow bin should be used for discarding anatomical waste, human, animal body parts, tissues. Soiled waste items contained with the blood and body fluids like dressing, cotton swab, and bag containing residual blood products. Chemical waste used in production of biologicals. Microbiology, biotechnology, and other clinical laboratory wastes. Blood bags, laboratory cultures, stocks of specimens of microorganisms, live or attenuated vaccines, human animal cell cultures, discarded linen contaminated with the blood or body fluid, including masks and gowns. Translucent white box should be puncture leak and temper proof. Sharps should be discarded in this. Needles syringes with the fixed needles from a needle tip cutter or burner, syringes, vacuum scalpel blade, any other contaminated sharps to be discarded in translucent white box. Blue box container with the blue colored marking, puncture and leak proof box. Glasswares, broken or discarded glass, including medical vials, ampules. All glass particles has to be disposed in the blue box. Broken or discarded contaminated glasses. So biomedical waste color code, that is yellow, non-chlorinated plastic bag, separated collection system leading to effluent that is used for dispose of human anatomical waste, animal waste, soil waste, expired or discarded medicines, chemical, microbiological waste. Red is used for contaminated waste, which is recyclable. That is plastic tubings, bottles, intravenous tubings, sets, catheters, urine bags, syringes, and gloves. These all plastic things should be discarded in the red, which can be recycled by using autoclave, microwave, hydro, and then set to for recycling. White is used for discarding sharps. Blue is for the glasswares. Labeling of biomedical bag. Schedule 4, label for the transportation of biomedical waste. Contain bag, day, month, year, date of generation waste, category, waste class, waste description, sender's name and address, receiver's name and address. In case of emergency, please contact number should be available at the bag. These are the referrals. Thank you. So I'll talk about the fever clinic. Fever clinic is an outpatient facility where patients could come in when they have fever or fever accompanied with multiple other health-related issues. Patient would evaluate and use evidence-based clinical protocols to diagnose the cause of the problem. Fever could be due to multiple reasons, and one of them could be possibly be viral infection like COVID-19. Screening, every patients need to be screened at the entry point of the clinic. In the hospital, patients with the fever should be directed to the fever clinic. Out of the patients who are evaluated in the fever clinic, the ones that will be suspected to have viral infection like coronavirus will have to undergo tests for confirmation of the diagnosis. Fever clinic need to be set up in the place that is away from the main traffic of the hospital building area, preferably with a separate entrance. If you do not have such area, please do not start a fever clinic. This is to ensure that we are not mixing the patient's flow address, the paranoia of the regular patients. One consult room with a separate entry and exit. Room should be segregated from the regular area. Separate area in the outpatient zone with separate air conditioning and ventilation is required. Waiting areas to be segregated from routine checkup area and fever clinic areas. Manpower and equipment required in fever clinic, people that is a senior doctor, nurse, housekeeping staff, and security. Equipments are the portable X-ray, table, chair, basic monitor like thermometer, NIVP for blood pressure measurement, stethoscope, stretcher with oxygen cylinder, pulse oximeter. Better to have a multi-para monitor with the 5 parameters where a quick immediate recording of the vitals can be done after attaching to the patient. Responsibility of the front office executive. Front office executive ensure that she is wearing mask glove with through clinic operating hours. Front office executive needs to be initiate billing post receipt of payment only through the digital mode. Team to ensure the patient documents are received via soft mode, printed and kept ready for collection by the diagnostic. Doctor will be trained GP, AFP, or internal medicine qualified doctor to ensure that she is wearing a protective gear as per COVID-19 protocol while inside the consultation room or isolation room. Doctor to be inside a consultation room isolation through the session minimum for 9 a.m. to 1 p.m. Doctor to ensure hand sanitation protocols are followed by both doctor and patient. Doctor to dispose the protective gear at the end of each examination session of the fever clinic room. Hand sanitation protocol to be followed after discarding the gear. Responsibility of the nurse is to ensure that to wear the PPE kit inside the sterile room. Sample packing to be done as per defined protocols. Nurse to be inside the sample collection room through the session minimum from 9 a.m. to 1 p.m. Hand sanitization protocols to be followed after the discarding gear. Housekeeping staff to ensure that they use a sterile room to wear PPE kit and complete surface cleaning activity after each patient visit in consent to isolation room. Housekeeping staff to ensure to enter sample collection room through the staff entryway and dispose biomedical waste along with their own kit. They need to be follow biomedical waste disposal protocols. Clinical protocols for the fever clinic. Doctor will be trained GP, internal medicine qualified doctor. The doctor will be wearing PPE for the encounter. Doctor will follow standard patient examination protocol as laid down by Hutchinson's clinical method. Post consultation, possible clinical etiological maybe patient may be having COVID-19 fever due to any other etiology, fever of unknown origin where COVID-19 cannot be ruled out. You can see the images where how doctor is sitting with a full PP and staff nurse with a full PP gear and the patient sitting in front of the doctor's table. Staff movement. Staff enters the floor in their streetwear and collect the scrub suit from the issue counter. Move to the change room and change to the scrubs. Keep the streetwear and valuable in the locker. Go to the donning room of the ward and do don appropriately. On completion of the shift, move to the dock room of the respective ward and remove the hazmat suit, N95 mask, other PP. Leave the donning room in the room in the scrub. Pick up the streetwear from the locker. Take a shower. Go on. These are the personal protective equipments. These include eye protection goggle, that is facial mask, surgical triple mask, N95 mask, gloves, coverall gowns, water resistant, and head cover and shoe cover. PPE donning and doffing steps, wearing a gown first, then a mask or respirator, then followed by goggle and the face shield and the gloves. So these are the steps. Step 1, put on the scrubs, put on the shoe cover, wash your hands, put on the N95 mask. So put on the cap, put on the surgical mask, and put on the goggles, then scrub your hands, put on the gown, then put on the gloves over it. Doffing, first is to remove the gown and gloves, then put on the examination gloves, then remove the shoe cover, gumboots, keep the rest of the hand gear until out of war. Remove the gloves, use hand sanitizer, wash your hands, then put on the new gloves, remove the goggles, surgical mask, remove N95 mask, and wash your hands. Then use a sterilium at the end of removal of all the PP kit. Protection levels, so these are protection level 1, level 2, level 3. Level 1 protection in case of disposable equipments are disposable surgical cap, disposable surgical mask, work uniform, disposable latex glove. Level 2 protection, that is disposable surgical cap, medical protective mask, work uniform, disposable medical protective uniform, disposable latex gloves. Level 3 are mask, medical mask, N95 mask, work uniform, disposable medical protective uniform, disposable latex gloves. Level 1, as you see in the picture, the cap, doctor is wearing a cap, surgical mask, scrub, latex glove, and maintaining physical distance. Level 2, you can see mask, scrub, latex glove, goggle, visor, water resistance gown with full sleeves. Level 3, you can see doctor intubating, wearing a mask, scrubs, latex gloves, goggle, visor, water resistance gown, full sleeve, full face protections. Screening OPD, healthcare workers, PPE required for screening OPD, N95 mask, goggles, gown, water resistance, gloves. Screening OPD for the PPEs required for sampling, N95 mask, goggles, gowns, double glove, shoe cover, and hood. PPE required for sample handling in the laboratory, N95 mask, goggles or face shield, gown and gloves. COVID ICU cleaning, cleaners or sweepers, they require N95 mask, goggles and face shield, heavy duty gloves, gumboots, gown, water resistant, hood. PPE required for COVID ICU, that is N95 mask, goggles, gowns, gloves, apron, hood, and shoe cover. PPE required for COVID ward, N95 mask, gloves, goggles, face shield, shoe, gown, water resistant, and a hood. In radiology, triple layer mask, an administrative area, cloth mask, homemade mask. PPE for OPD areas, healthcare workers, triple layer mask, cleaners and sweeper, triple layer mask, and heavy duty gloves. Ambulance for transporting COVID-19 patient healthcare workers require N95 mask, goggle, gown, gloves. Ambulance for transporting COVID patients, cleaners and sweeper, they should wear triple layer mask and gloves, heavy duty gloves should be there. Ambulance for transporting COVID-19 patient drivers should wear triple layer mask. Thank you. Swasthasya swasthya rakshanam, aturasya roga nivaranam. Swasthasya swasthya rakshanam means prevention is better than cure. Whereas aturasya roga nivaranam should be able to cure when you catch a disease.